So our objectives in this presentation will be to understand that the overactive pelvic floor is a cause of impaired defecation and can also induce chronic pelvic pain. We will acknowledge that the cause of pelvic floor activity is acquired. It is often linked to stress, and we'll see how we'll confirm the physical examination by using either manometry, ultrasound, or defecography. Finally, we'll stress the importance of physiotherapy and biofeedback to retrain the overactive pelvic floor. Well, everything starts for defecation by a sensation of rectosigmoid distension when the stool are passing and moving toward the rectum. And then at the same time we'll have the internal anal relaxation together with a contraction of the external anal sphincter so that we have time to go and to move to the toilet. Then when we're ready, we will just increase the abdominal pressure by doing a small Valsalva maneuver, and at that time we have to relax the sphincters and the puborectalis at the same time, and here we go. But we can have different mechanisms. We can have at the time of passing stool, a non-relaxation of the external anal sphincter, or worse, a contraction of the sphincter together with the pelvic floor. And then we'll obtain an acute anorectal angle, as you see here on the picture, and that will obviously do a perturbation of defecation and give a sensation of obstructed defecation. So when we have this impaired defecation, what do we have? We will have 1, the dysfunction, and 2, the pain. So let's see, for instance, dysfunction. When we have an impaired defecation, we have a high pressure in the pelvic floor level. So we will have to strain more to defecate, and will defecate less entirely the rectum. So we'll have a sensation of incomplete emptying, and we will strain even more, which at the end of the motion would give muscle shortening, and then we fall back into the vicious circle because it will aggravate the impaired defecation. This is the dysfunction, okay? But you can have also pain, because when you have this poor relaxation, then you need an abdominal contraction to overcome the high pressure in the pelvic floor, and you will obtain an energy crisis because we'll have contracted muscle needing energy, and at the same time contraction of the vascularization due to the muscle tone and due to the activation of the autonomic nervous system. And then we'll have a fatigue of the muscles, we'll have trigger points and myofascial pain, and it may be persistent if we have the co-activation of the autonomic nervous system at the same time. And this will generate a chronic pelvic pain. So that's a real problem. So, as we said before, what are the etiology? They are acquired. They are acquired very often during a poor training potty session. Then the child will have may experience some constipation, some pain, and then he will develop a circle of fear of pain, avoidance behavior, and then he will learn to contract unconsciously the pelvic floor while trying to strain. And we see in the pediology work that there is about half of the population of children suffering from this paradoxical contraction of the pelvic floor while trying to evacuate. And about half or 30% of the group will maintain this constipation in their adulthood. So that's one thing, but at any age we can stress the pelvic floor function as a defense reaction in case of, for instance, any kind of abuse. Then we may develop a somatization with feeling of anxiety, hypervigilance, and even though insomnia, having some kind of post-traumatic stress symptom in several kind. So this population suffer in half of the case of paradoxical contraction of the pelvic floor. Clinically, what are the symptoms? Well, the symptoms are a sensation of difficult defecation. We can see it in 20% of a healthy female population, and the need to strain to defecate. But is the need to strain a motor response, or is it a behavior dysfunction in relation to some kind of stress? This is a clinical matter that we'll have to open later. And the patient have very often a sensation of incomplete evacuation. Again, does it mean that there is an incomplete evacuation or just a sensation? This is the difference between a mechanical and a neural dysfunction. So as we said, the origin is constipation, and constipation withstands pelvic floor muscles. Frequently, we will have an association with anatomical dysfunction, anatomical structural abnormality in the pelvic floor, and we see rectocele and intussusception are the most frequent deformation of the pelvic floor while straining. So what can we do? Of course, we'll do a rectal examination, and we'll feel the high resting tone during the digital rectal insertion, and we'll feel, when we ask the patient to push down, we'll feel a non-relaxation, or worse, the contraction of the pubo rectalis and the external anal sphincter. But we will confirm this by manometry. We will confirm this by ultrasound, and we can do an ultrasound defecography or an X-ray defecography. So what is the benefit of manometry? Manometry will give us different things, different information. First, what is the rectal sensitivity? Hyper, hypo. It's important at the time of the physiotherapy to choose the right protocol. Then we'll see the synchronization between the anal opening while straining, or on the contrary, the dyssynergy at the time of pushing down, the patient will close the anus, and then we'll confirm the diagnosis. Pelvic floor deformation can be seen by doing an X-ray defecography. You see here the rectocele. On this picture, the anterior bulging of the rectum. You see the intussusception when the rectal is falling into itself, and this can give us an obstruction of the anus, or the pressure of an enterocele, or the dysfunction secondary to descending perineum. But of course, the problem of defecography is we see only the rectum, and there is some kind of radiation, which may be a problem into young patients, and especially young female patients. So we are using ultrasound defecography. It is a technique we described in 2002 and was published. The important thing is that we see exactly the same as X-ray defecography without X-ray, and even more, we will see all the pelvic floor organ. And this is important because it will also give us a lot of clue to understand what's going on. Let's see here a motion here. You see this is the anus, and you see while the patient is straining, the development of this anterior pocket here, which is a rectocele. He is filling the rectocele, but he is not relaxing the external sphincter of the anus, so nothing is going to come out. So this is important because we know exactly the mechanism, and we will know also if there is some kind of prolapse of the uterus or of the bladder at the same time, which is important at the time of choosing the right treatment. So We published this last year, and we saw in a population of 105 female patients suffering either from constipation or incontinence that ultrasound and X-ray defecography are two techniques in very good agreement, if you can see here, depending of the kind of deformation of the pelvic floor you can see at that time. I must say that ultrasound had also gave us another information about the functional evacuation that defecography was not able to give us. So, if we're speaking not on dysfunction but on pain, we have two different situations. One is a chronic proctalgia, chronic rectal pain. It's a recurrent pain. It lasts at least 20 minutes. And when we'll do the rectal examination, if we have the pain at the level of the levator ani, we'll call this a levator ani syndrome. Otherwise, it's a kind of unspecified functional anorectal pain, meaning also that we can have pain in many other muscles of the pelvic floor. The other situation is a proctalgia fugax. It's short, very intensive pain lasting from seconds to minutes without any pain in between. So these are two different mechanics to explain the pain that we can feel when we have this overactive pelvic floor. What is the treatment? Well, there is always a first step to exclude if there are alarm symptoms such as bleeding or at a certain age we will do in this case a colonoscopy to exclude some kind of mechanical obstruction. And then otherwise we'll give a first treatment with diet, fibers, and then we'll choose one of the medication. Nowadays we're using very frequently medication based on polyethylene glycol as a first treatment, and otherwise we'll decide to use one of the newer medication to treat this constipation. Well, biofeedback is very good for a very good treatment for dyssynergic condition. It gives good short-term results, which can be understood, but I think that the most important is that it gives also long-lasting good results, as you can see here is this publication, and it's in any case better than laxative, or it was also compared to sham biofeedback. So we are here in the process of conditioning and relearning of something. Therefore, we can have good results and long-lasting results. So, but biofeedback was also good to relieve the pain related to the overactive pelvic floor. And in this publication from 2010, we saw that biofeedback solved 97% of the case of the pain and was much better than electrogalvanic stimulation or massage. So that's important. If biofeedback is not helpful, then we can use either dry needling in the muscles or in the trigger points in the subcutaneous area, or injection of mainly lidocaine as a sedative or Botox. Otherwise, we will use medication against pain, gabapentin, pregabalin, dulexin. Well, TCAs will not use them too much because of the side effect of constipation, and we don't want to add constipation to the symptom of this patient. But we can also have very good results in case while using alternative methods such as cognitive behavior therapy or hypnosis, and this was also reported in publication. What are the results? The results are sparse in the literature. Mainly we have uncontrolled study, but we can see that the best result can be obtained here if physiotherapy is not enough to treat this patient by sacral modulation. So the approach shall be multidisciplinary when you have a patient with constipation and pain, and as we say, treat the constipation, do some physiotherapy, treat the pain either by medication or by non-pharmacological treatment. Thank you.